Welcome, listeners. I'm so excited to introduce you guys, if you haven't met her already or read some of her articles or seen her on different interviews, Dr. Michelle Teo. Dr. Michelle Teo, you are currently in Toronto, but typically you're in Penticton, yeah? Penticton,
Yeah,
BC.
that's right.
That's right. And you and I, we met. Uh, one of the times we've met was in the context of you presenting um, kind of an innovation around how to run clinical teams better. And I was blown away by that presentation. It was in the context of one of the physician quality improvement tables, and it was fascinating. I loved your passion there because it's something that I feel is really missing from primary care where I work in Surrey, where we don't have we don't have teams. We have like family doctor and an MOA. So this topic is really interesting to me, and I know that you're super passionate about it. Um, how did this idea come about? I mean, I read in I don't remember which publication it was, but that you had an experience with burnout, similar to myself. Like I burnt out 4 or 5 years into my career, just trying to do too much, bridge the gaps of the system by myself in a silo. So tell us about that experience, if you can, about your clinical burnout stuff.
Absolutely. Absolutely. And thank you. I'm just so honored to be here and talking with you, Dr. Lawrence Yang, but please call me Michelle. So, yes, very, very true. I have most certainly experienced burnout. But what I think it's important to understand is I've also always had an interest in what we could now call team-based care. But 15 years ago, it was called models of care. So how can we think of different ways to provide care to patients? And my interest specifically was more in outpatient setting. And so during my residency, I'd always ask, does it need to be like this? Or what are your thoughts, preceptor, on if we were to change things, the process a little bit? And, I'd just be told, look, Michelle, the system's a system. You want to have fun and make some changes. You go off on your own. For the love of God, just stay out of the academic world and
Wow.
do what you need to do. And I said, absolutely, I hear you. So in my first year of practice, I inherited a 39-year-old practice. My husband and I both started. He's a surgeon, a urologist, and I just started rheumatology, thinking I knew what I could. I could really handle it. I was, just passed my exams. We all know it takes a good year or two to really get your feet wet. And I burnt out in my first year. We had two other kids. I just couldn't do it. And even after pulling away, I had to reflect and say, okay, I have 700 patients that I inherited. All of them require ongoing care because they're rheumatology patients. I can't see new patients. I can barely fit the existing ones in follow-up. I am not meeting the needs of my community. What needs to change? And so, yes, I needed to regroup and get my energy back. But I also needed to figure out another way to be able to do this that could meet the needs not only for myself and my personal life, but also work. And that is when I hired my first nurse and really started to experiment and say, okay, how do we make this work in a fee-for-service model so that it can be continually something that we work on and potentially grow and improve upon? And
Mm,
that's what I've been doing for 10 years.
wow. So you've always had an innovator spirit, and it sounds like your preceptors are like, you can't change the system. They're kind of like trying to shut you down, keep you in a box, Michelle. But you can't do that to Michelle. As a rheumatologist, you of course take referrals from all sorts of some specialist colleagues as well as family physician colleagues from the hospital for different presentations of maybe autoimmune disease or joint pains and stuff. And you and your MOA and now your nurse and your team will actually try to figure out how to make their lives better, try to identify the cause of some of these things. Is that right?
Well, that's right. So, I mean, just to briefly describe the model, I mean, for those of you that are watching and listening, think of your best resident. If you take residents, imagine, Lawrence, we spend like 4 weeks training someone. They finally understand how we want things done, how we want to hear things said, what tests need to be ordered. And then they go.
And then they go to the next rotation. The next rotation, yeah.
And you think, now imagine that person never leave. That is the model we're talking about. And
Ooh.
now this person will always be able and continually improve, but really understand, okay, how does Michelle need to hear it so that she can maximize her time, still seeing every single patient, but maximize her time diagnosing, treating, and problem solving. Because Lawrence, that is what we went into so much debt and sacrificed our 20s and 30s for. It was to do these essential things, but 90% of our day or more is spent on a ton of other stuff. If we could trust someone who we were involved with the training to be able to support us through this journey, then they could take a large chunk of this. We can focus on doing what we were trained to do while still really developing that very important and strong therapeutic relationship. So I'll give you an example. As a rheumatologist, do I need to be asking how long's your morning stiffness, or how many NSAIDs are you taking per day, or when was your last flare? Absolutely not. My nurse is involved with doing the targeted, focused history and physical exam. But when I come in and within 20 seconds hear what's happening, a picture is being made for me right in front of me. And of course, if there's a nose missing or an arm missing in that picture, meaning it doesn't quite make sense, I'm right there and I can really learn and figure it out right from the patient, and my nurse is learning on the spot there. But once we sort that out, now me and the patient have dedicated time to focus on the things that they care about the most. Because now I can jump in and say, oh my gosh, you can't ballroom dance anymore because of your rheumatoid arthritis, because it's flaring. Like, we got to deal with this now, don't we? Right? I don't, morning stiffness doesn't even play a part in that conversation. Me being able to quickly connect and understand what the patient is and spend that time working with the patient to decide, all right, what is that best treatment plan that this patient's going to feel comfortable with? And at the same time, my nurse, it could be any AHP, is involved with prepping and getting a whole bunch of documents, lists, whatever, ready for the patient for after when I leave, and all this counseling and education can take place. And the doctor just keeps going back and forth to do that. That's how I was able to increase my patient capacity from 700 to over 3,000. And
Wow.
I saw every single patient. And what we wanted to see is that applicable to other specialties, which is where specialist team care comes in. But you know me, I can talk forever about this. So I'll wait until it's time for you to specifically ask a specialist team care question.
Got it. And for me, like one of my, if I was to analyze like when I burnt out, it was because I was in my clinical practice, in my clinic, kind of like an island, kind of like a silo, separated from my other colleagues who were innovating on their own, separated from the hospital where there was team connections and stuff within the specialist and physician, like the hospitalists who were working in, like I was really isolated from them. Part of my recovery from burnout was learning to network, meeting other folks, and then actually forming teams in other ways, like maybe innovation, like think tank teams, like in physician QI that we have. And also part of that was also learning to trust, as you said, trust my MOAs to do stuff. Like I wasn't trusting them enough, and I wasn't delegating tasks, so I was really getting burnt out too. I wasn't maximally uh, using my team properly. Were your keys to recovery from burnout similar? Like you mentioned just now how your teams might work. You're trusting folks, you're delegating tasks, you're parallel processing stuff. Are those some keys to burnout, you think?
Well, okay. So, I mean, there's so many things that I want to address here. So the first thing is, when I came back from burnout, I had to take 6 weeks off, and I couldn't look at anything. Actually, I think it was closer to 3 months. I had to take that time off and just re-energize and become a human being again. And then think about, how am I going to go back to this that burnt me out, and face that. And with my nurse and I, we did so. But shortly after I went back, my eldest daughter got diagnosed with a very rare form of juvenile arthritis. And when I speak at previously only to rheumatologists, I would ask the audience who here has either been personally or has a loved one touched by one of the conditions we treat. Generally, one or two people, right? Definitely not the majority. I thought I was a really good rheumatologist up until I had to be on the other side of that therapeutic relationship. And I tasted that incredible vulnerability and helplessness of watching my loved one suffer. And I mean, my daughter, she's had a great outcome. I mean, within a month of her having this super weird, form of JIA, I mean, she sees people in Toronto. She gets tests that aren't available in BC. I mean, she's in remission. All these incredible things happen, but it's because I was in the system and I was able to expedite things. And so when I had to come back to planet Earth and think about, okay, there are over 500 of my patients waiting on a wait list, feeling just as helpless, them and their loved ones feeling just as helpless. Whatever I do to help manage my burnout, it can't come at the cost of them. We have to find a way for both parties to win. And as you'd say, team-based care, and it can be in many different types of forms, but that's the goal. Now, why do I love team-based care? Because when you share that same vision, all right, your best resident and you share the same vision for your clinic, and you are on the same wavelength, oh my God, like there is nothing that you can't achieve. That synergy of energy, of desire to make something better. And the amazing thing is that you empower each other. You make it happen together. And the type of team-based care that we're talking about, that I have most knowledge about, not all team-based care, it allows teams to be as empowered, but it can be. So on that note of recovery, what does that look like? Well, knowing that I'm taking care of myself and those 2 to 3 hours of unpaid admin time, which even if we're paid, I mean, like, it better be hundreds of dollars, baby. Because we're definitely, like, our diagnosing, treating, and problem solving expertise is very, very valuable. That's gone. I don't need to do that anymore. I pay someone $55 an hour to help me do that. I still am in the know for everything, but now I'm able to be at home for those 3 hours that's all I got towards self-care and towards my loved ones. And yet I know my patients are not going to be paying the price for that. And when I go to work, I may drag my feet. Actually, I'm not a morning person, so a lot of mornings I drag my feet to work. But as soon as I get there and I'm there with my team, I mean, it's like game on and we are set to go. I wish, why can't marriage have that same synergy? I don't know. Winston, I hope you're not listening. I'm kidding. But it's incredible. It's absolute, and it in itself is healing.
You're really excited about this, obviously, and passionate about it. You call it specialist team care. How is specialist team care different from, I don't know, what other people's team-based care concept might be? What's different?
Right. So um, there are different types of team-based care, and all of them have their place. All right. There is no one size fits all for team-based care. There is no one size fits all for healthcare reform. So it's important to recognize that this is just one option. This is an option for physicians who have outpatient care that have a fee-for-service payment model or something along those lines. It's an option for you to be able to hire your own nurse or AHP, so allied health professional that is best suited for your specialty, and to work together to be able to see more patients. And because you're able to see more patients and provide high quality care, and the patients feel heard, they do not feel rushed, they feel very cared for. Because you're able to see more patients, it pays for your allied health professional nurse. In fact, because it's not hard to loosen the bottleneck just with one nurse or AHP, people actually find they make more money. So people, as I was saying, how you use your nurse AHP depends on your needs. A nurse could be doing some admin stuff while you're still seeing lots more patients and billing consults and follow-ups and what have you. Your nurse could be helping you with seeing patients while you are seeing some patients. The ideal scenario for us to maximize our expertise and to work top of scope is to have two nurses AHPs where you just kind of go back and forth, and it's pretty phenomenal, the efficiencies that are created. Through specialist team care, the whole point was to take my team's model and say, all right, Michelle, you did really great. Can you apply this to other specialties in outpatient care? We took 9 different specialties, and through a grassroots, bottom-up approach, lots of mentorship. You get trained by individuals who are experts in their area and who have done this and succeeded in it. On average, the teams were able to increase patient capacity by 100% in 6 months, with over 90%
Wow.
patient satisfaction. I should mention, however, just because on the burnout, one site is only increased by 25%. Well, I mean, it's still a lot. I know, here I am,
Still a
it's
lot.
only 25%. He only increased 25%, but that was intentional. You want to know why? Because he said, my family liked me again. He
Mm.
said, this has completely changed the dynamics of my life outside of clinic. And I will not, I mean, he saw what a game changer it was to his personal life. And he said, that's it. He can always grow. He can always take it further. But with young children, he said, this is it. And that's enough for him. And that's the beauty of it. You get to decide how far you want to take it. And then we have a pediatrician. She's increased patient capacity. A shout out to her, over 300% for children with autism spectrum disorder and youth mental health.
Wow.
Believable. Unbelievable.
Wow. You know, for this show, we have this graphic. This is increasing population health. This is patient experience here. This is health provider experience, and this is cost neutrality or resource stewardship. It sounds like your team-based care addresses all of the quintuple aim, um, and that's amazing. And it addresses the burnout challenge and keeps health professionals healthier, happier, maybe retains them in practice longer.
Oh, absolutely. Absolutely. I mean, and we see articles, I can guarantee you and I see the same articles once a week talking about whether it's nurses, other allied health professionals, or even physicians wanting to leave. It is that moral distress that they experience, all these different roles experience. Specialist team care, I mean, it completely warms my heart when my team and I go to see these sites, and they're working and they're collaborative, they're synergistic, and the incredible things that they achieve, and they are so proud of what they have done. And again, knowing that they can continue to grow. There's one site in particular, I mean, they're just getting started. I know that there is so much more that they're going to achieve. And then we have other sites, as I said earlier, that say this is good for now, but I mean, the potential's there. I just need to catch my breath because it's been many years, probably their entire career as a physician, since they felt this grounded.
You know, I know you're very busy. You're in another city right now, and you have interviews to do and with different news outlets, and you were just presenting to the UBC School of Business, the Sauder School of Business. Thank you for your time again. What is the secret sauce of specialist team-based care before we let you go?
Lawrence, you and I see time and time again that top-down change initiatives are not as successful as hoped. We see team-based care everywhere. I mean, there's a hospital as an example, and yet we see a lot of the time it doesn't reach the potential that we know it is possible. I mean, the data says team-based care should be able to achieve X, Y, Z. Why are people leaving hospitals in droves? Why are we having the problems that we're having now? Of course, it's complex, but nurses are leaving the hospital not because they feel, well, it's because they don't feel good at work, because they can't handle this work-life balance. Doctors are leaving because of the moral distress that they feel. They know they're capable of so much more, but the system prevents them from it. The secret to specialist team care is that it's the people on the ground that are empowered, my favorite word. They are empowered to create the model that works for them, their specialty, their patients, and community. It is a bottom-up approach that allows that flexibility that is appropriate for the people involved. And you and I, Lawrence, we've talked about it. It's not the content. The content's out there. I mean, how long have been people talking about team-based care or high-functioning teams or what have you? It's respecting and honoring the human experience as you create it and allow it to grow and evolve. That is the secret sauce. And so by having somebody who understands it in that role, mentor others that are learning it, that is what allows these incredible successes to happen.
Wow. If someone wants to taste some of that secret sauce, how do they get in contact with you or your team?
Absolutely. Please email me at MTEO, Michelle Teo, at Balfourmed, BALFOURMED.com. And I would be more than happy to talk to you at length or not about specialist team care, which I'm very, very passionate about, as many of you know. You also may have seen some campaign material out. We have a Better Care for BC campaign going on right now. It involves less than 30 seconds. You can write a letter to your MLA and Minister Dix, informing them how critically important it is that we spread specialist team care to as many physicians and patients as possible. They have a proposal, likely collecting dust, but really a proposal I've sent to them saying, look, this is how we can do it, and BC can be the leader. I truly, deep down in my heart, hope that this can be a reality.
Thank you so much for your time. It was a pleasure, and I look forward to talking to you again sometime.
Likewise, Lawrence, thank you so much for having me. Have a lovely evening. Okay, bye-bye.